Okay, so it's 5:05. We might begin. So hi everyone, welcome to today's session, and thank you so much for being here this evening to attend our webinar sessions with Anita Parkins. I'm Shabrina, and joining me today will be Dr. Teo Boon Han, and it is our pleasure to be your host for this evening. So if there's any problems that you guys are facing throughout the webinar, just let us know, send us a private message, and we'll be happy to sort it out for you. Also, for those who don't already know, this is part of the 3 sessions of webinar sessions that is organized by the Singapore Veterinary Nurse Technician Chapter, which is supported by the Singapore Veterinary Association. Sorry. And so just briefly running through with you guys our chapter's committee. We've got Dr. Teo Boon Han, which is our chair, Ms. Allison, our co-chair, Dr. Eleanor Ho, who is a member, Mr. James Lowe as a member, Ms. Lydia, Ms. Xue, myself, Ting Yi, Yvonne, Claudia, Clara, Valerie, and Tizhen. So this is the program flow for this evening. We'll have a welcome address by Dr. Yap Him Hu, followed by the webinar session itself, and finally closing with the Q&A session and the closing address. I would like to introduce our guest speaker, Dr. Yap Him Hu, who will be opening today's event. He is our Director General of the Animal and Veterinary Service and our Chief Veterinary Officer in NParks. Without further ado, Mr. Yap, please.
Thank you, Shabrina. Right. Dr. Teo Boon Han and Ms. Alison Wah, the co-chairs of the Singapore Veterinary Nurse and Technician Chapter Working Group. Ms. Anita, our distinguished speaker for today. Ladies and gentlemen, good afternoon. First, I would like to thank the working group for inviting me to give the opening remarks for this webinar. It will be a brief one, I assure you. It's really a pleasure to be here. Before this, I had a very fruitful discussion with the chapter working group. The members have expressed to me some of the aspiration that they have for the professions, as well as what they think is needed to realize this aspiration. We spoke, I think it was a short session, but I think we got quite a fair bit of, I got quite a fair bit of insight into what the profession wants and what the profession needs. And I have assured the members that the Animal and Veterinary Service in NParks would like to partner SVA as well as the working group in creating an environment where the aspirations will be met. And at the same time, we will make sure that whatever the profession can do or will do can contribute to society and the community at large. I think that's something that I have stressed that is important for the profession to show. The formation of this chapter is actually a significant one, and I must congratulate the Singapore Vet Association as well as the professional in getting this done. And it's for the very first time, I think a collective voice can be heard from the profession. And it's also an opportunity for the profession to speak up and make their voice heard by us, in those in the government service. And at the same time, internally to formulate your own curriculum for your professions so that your professional standards and will always be enhanced or continually be enhanced. I think those are quite important steps, and I encourage the working group to deliberate on this, and we'll be happy to work with you. Okay. I think, as I mentioned, this is perhaps it's just going to be a very brief one, and I wanted to first of all encourage the people attending this webinar, if they have not joined as a member, associate members in the SVA, and please do so, because I think it's one way for you to get CPE, to get access to some CPE events as well as materials. And SVA, I'm a member of SVA, and so is Boon Han. We definitely want to encourage you to do that. And this will definitely be the first step where you can look at upgrading the professional standards in the vet nurses profession as well as the technician. Lastly, I want to thank a few people. First, I think SVA for supporting this series of webinar, and also definitely the formation of this working group. I would like to thank the members of the Singapore Vet Nurse and Technician Chapter Working Group for their hard work, and Temasek Polytechnic's Dr. Lau Ji Zhen and Ms. Valerie Koh for their support in the working group as well. As we want to highlight the importance of the Institute of Higher Learnings, their role in the chapter, in the work of the chapter. With that, I would like to wish you guys a very fruitful discussion at the webinar. Thank you.
Thank you once again, Dr. Yap, for your time and for being here. Now, I would like to introduce Ms. Anita Parkins to this. So Anita is an accredited veterinary nurse with the Veterinary Nurse Council of Australia. She holds diplomas in emergency and critical care, surgery, and is a certified veterinary pain practitioner through the International Veterinary Academy of Pain Management. She is also a veterinary technician specialist in anesthesia and analgesia. And I'll hand over the session to Anita, who will present this evening's session and with regards to anesthesia and analgesia for the veterinary nurse. I'll now hand the session over. Anita, please.
Thanks, Sabrina. I'll just get my screen sharing up. Sabrina, were we just able to share that screen?
Yep, in a moment.
Sorry.
Okay. All right. Okay. Okay. Can everybody see the screen? Okay.
So, Sabrina, you're going to have to change the slides for me because I don't have access to flick through them.
It's okay. I can make you the host as well.
That's okay.
Okay. Anita, I think you can share screen now. Are you able to?
Yeah. I'll stop sharing and Anita can share.
Yes.
All right.
There we go. That's perfect. Okay. Can we all see the presentation?
Yep.
Yeah.
It's great. Yeah.
Okay, so welcome everyone to today's lecture on anaesthesia and analgesia. We have a lot to cover tonight, so hopefully we'll get through it all. And please, if you do have any questions, we do have a question and answer session at the end of this. So make sure you jot down all the questions so we can get to them at the end. Okay, so tonight we'll be covering setting up. So setting up for anaesthesia, the pre-medications, induction agents, plans and stages of anaesthesia, intermittent positive pressure ventilation, different types of analgesia, the recovery process, and also different emergencies that we will see within the surgery department, be it through anaesthesia or in the recovery phase. Okay, the primary causes of errors with patients are mostly human and equipment errors. Recent human studies have shown that just by having a checklist, just by having a surgical checklist, it can actually decrease the errors that are actually made with our patients by up to 50%. And this is in the human field. So hence we've adapted this into the veterinary field. So we can actually eliminate as many errors as we possibly can to make it safer for the patient. So each and every patient that goes through to be into the surgical department or anaesthetized, we have this checklist available for them. We go through this checklist with the surgeon before we anesthetize the patient, and this is going to be covering bloods that we've been running, the patient's name, which leg are we doing? Is it the correct leg that according to the charts? If there's been bloods run, has the clinician actually overseen the bloods to make sure that we don't have to alter any of our techniques with the patient that we would do normally, what ASS physical status is of the patient, which we'll go through in a little bit. What the surgeon actually requires us to do. So are we expected to give antibiotics? When should we start those antibiotics? Is there any expected complications throughout the surgery? So if bleeding is expected, is there blood on standby? All of those sorts of things, so we can try and eliminate the errors as much as possible. The next primary cause of errors within the surgical department is equipment errors. And by running through our equipment, making sure that our equipment is up to date, serviced up to date, we leak test our anaesthetic machines, we make sure our fluid pumps are all plugged in and working, all of those sorts of things, this can again decrease the amount of errors that we see come through with our patients, and also give our staff that are actually running these anaesthetics and the entire surgery department a little bit of a safety blanket, that we know that we have gone through this checklist. We know that we have gone and checked every piece of equipment before we actually need to use it, so we can pick up on if something's not working before the patient is anaesthetized. Okay, so setting up for the patient, we need to, the whole idea of taking a history of the patient is to detect abnormalities before the medication is given. So that includes pre-medication. We want to tailor the anaesthetic needs to the patient, and even though we do have protocols within the practice, each and every one of our patients has the anaesthetic tailored to their needs. We want to be able to tailor fluid therapy requirements to the needs of the patient. So if it is a heart patient, if it's a neonate or a pediatric, we want to know that we can decrease those fluid requirements. If the patient has renal failure, what's the extent of renal failure before we go ahead and anaesthetize the patient. Make sure that the owners know what procedure the pet is actually having. There's nothing worse than the owner coming in and thinking that their right leg is having surgery, and when they come in to pick up the patient, their left leg has been done. Now, both legs may need doing, but they thought that the right one was getting done first. So we always like to confirm the procedure with the client at time of admission. The other thing that's really good is if they're coming in for a lump removal, notice and point out, even if you have a map drawn of a patient, and that way you can circle on the map where all the lumps are. So there's no surprise when the patient goes home that the owner knows exactly what procedure their pet is having, exactly what lumps are being removed. So when they come and pick up their pet, it's exactly what they thought it was going to be. Part of this, we want the admittance form filled out, which means that they're going to give us consent to go ahead and perform the procedure. We want to know if they have had anything to eat at all. Are they on any current medications? When were those current medications last given? As a nurse or a technician, this can tell us a lot, and this information can be taken back to the vet. So have they eaten? No, they haven't eaten since last night. Yay, they've got an empty stomach, or should have an empty stomach. Are they on any medications? Yes, my pet's on Medicam or Meloxicam. When was that last given? That was given this morning. As a nurse or a technician, we know that that should be given with a full meal. So that will then alert us to the fact that we have to go and tell our surgeon or our clinician that this pet has had a non-steroidal anti-inflammatory without any food. So therefore, we can go and take the precautions from there. Are they on any heart medication? When was the last time they got it? They didn't get it until last night. The cardiologist or the clinician may actually require it to be given that morning. So therefore, we can go ahead and give a dose of that medication. So again, we're decreasing the side effects that we're going to see, or the complications we are actually going to see with the patient. Owners will tell you if their patient is allergic to any drugs. The classic is, my boxer is allergic to ACP. They're not actually allergic to ACP, but they have side effects. Somebody has told them that they're allergic to the drug. This is the sort of information that we want from the client. If they've had an adverse effect to a medication, and they may not have been seen at your practice, they may have been seen elsewhere, they can say, last time the patient was anaesthetized, he had this and there was an adverse event with that. So therefore you can try and limit the amount that you use that drug, or totally not use that at all. And this is the information that can be then taken back to your clinician so they can make an informed decision about the drugs and what you're actually going to use with the patient. Are they eating, drinking, urinating, and bowel motions all okay? One really good reason that we're asking this is because if they've got an increase in appetite and an increase in drinking consumption, what are their renal parameters doing? Why are they doing that? Are they on cortisone? It can stimulate the nurse or the technician to ask more questions and get more information from the owners. And really, you are better off asking open-ended questions to get all the information than straight yes/no questions, because that way the client is going to give you all this information. Is the TPR normal for the pet? We take them in on admittance, we TPR the patient. Is it normal for that particular animal? If it's not, we then further investigate. This is an X-ray of aspiration pneumonia. If our client hasn't told us that the patient has fasted and we go ahead and anaesthetize the patient and he regurgitates under anaesthetic, this is what they can actually end up like, with those really moist, wet, white lungs. And that's not what we want. We want nice black lungs in an X-ray. And again, this is a complication and can be fatal to the pet if we don't treat it, or if it is severe enough. So through the TPR, we're looking at the singlement of the patient. So the singlement's going to cover the breed, the weight, the age, the sex of the patient. And yes, all this whole TPR is going to take you about 1 minute to do. The breed of the patient can alert us to factors like, are they predisposed to different issues that we know about? For example, going back to our boxers, they're predisposed to having side effects when acepromazine is used. That is not an old wives' tale, but we tend to have bred that line of boxers out of Australia. We did see a lot of it. We don't see a lot of it anymore. If the patient is a schnauzer, they're prone to sick sinus syndrome, so a heart disease. So this is what we're going to look for. Now, sex, the age of the patient is not actually a disease. So just because a patient is old, it is not a disease process. However, it can alert us to alter the anaesthetic or analgesic protocols to the patient and what they actually require. So we will treat them just a little bit differently. What's their respiratory rate and effort? If they're tachypnic, like a really fast heart rate, if they're tachypnic and the effort is increased, we have to go and listen to the lungs and find out why. Can we hear dull lung sounds? Is there crackling in the lung sounds? Again, it's not up to us to diagnose as nurses and technicians. However, it is up to us to alert the veterinarian if we pick up something that is actually abnormal. And then the clinician can assess the patient and go, yay, we've picked this up. Thank you so very much. Listen to the heart and also feel the pulse rate at the same time. So the heart rate and the pulse rate is two different things. Majority of the time, each beat of the heart, you will get one pulse that you feel. However, that's not always accurate. If you do have pulse deficits, that means listening to the heart, you have a higher heart rate than what you actually have as a pulse rate. This can lead the nurse and technician to go to the clinician clinician, and the clinician may say, hey, let's run an ECG and see if we have any complications with our heart from there. The temperature of the patient, are they pyrexic? Why are they pyrexic? Let's look further into it. If they are really hypothermic, so really cold, we have to warm them up before we start administering drugs, because drugs are only going to cause them to get cooler. What's their mucous membrane colour like? We're looking at pink, blue, grey, muddy, black, red, white. All of those sorts of colours can tell us something that is underlying with our patient. Ideally, we want a pink with a refill less than 2. However, I get you guys to all go back to your practice, and when a patient is recently deceased, whether they be euthanized or pass away, I want you to check their capillary refill time. It will be normal. It will be between 1 and 2 seconds if they have been recently passed away. So don't always take a capillary refill time as gospel. The patient is okay. All it means is there's still blood within those membranes at that point in time. Looking at the physical status of the patient. So this is how we categorize how healthy our patient is. So level 1 is a normal, healthy patient with no disease process at all. So we're not a neonate, we're not a pediatric, we're not a geriatric, we're of the adult age with no disease complications. A level 2 is a slight or moderate systemic disease causing no obvious incapacity. So this is our neonates, this is our pediatrics, this is our geriatrics. We may be in renal failure, but we're not showing any signs of renal failure. Again, we may have heart disease, but we're not showing any signs of heart disease. Level 3, slight to moderate systemic disease causing mild symptoms. So we've got a renal patient that has got elevated BUN creatinine, and we do have an increase in fluid intake. The patient is dipsic polyuria. So those sorts of things. The patient may have liver disease and they may be slightly jaundiced. Level 4 is extreme systemic disease, and it is causing a threat to life. So think of your renal, heart, liver patients that are on medication to keep them going through. It's a constant threat of life that we have to be mindful of when we're actually treating the patient with anaesthetic drugs. Level 5 is morbid or dying. They're not expected to live 24 hours with or without surgery. So these are generally, a lot of it is your emergency patients that come in that aren't expected to live. They may be a patient that is in had severe systemic disease. And they have given a poor prognosis if the patient is anaesthetized. There is also a level 6 physical status, and generally that is reserved for the human field because they are actually organ donors. So they are actually kept alive just so that they can donate their organs. And then you can have level 1 to 5 and also an emergency. So you can have with or without your emergency, depending on how the patient actually comes in and what they need doing. So putting all this information together allows you to make informed decisions about the patient's medication and what they are actually going to receive. It's going to alert you to inform the veterinarian if anything is out of normal, and then they can come up with the plan that you're going to use with the patient. Gives you ideas on how you're going to treat this patient so that you can keep the patient as safe as possible throughout the entire perioperative procedure. All this information then is taken back to the vet so they can make an informed decision about their patient. Remember, we're working on their behalf. We're monitoring the patient on their behalf. They're the ones that are going to make all the decisions about the patient. Okay, so now we're going to prepare the anaesthetic equipment. We make sure that the anaesthetic machine is all set up. We're going to have the monitoring all set up. The anaesthetic machine, each and every time before a patient is connected to an anaesthetic machine, it must have a leak test. So closing off your pop-off valve, holding off the end of the circuit, the circle system, and then you're going to turn up the oxygen flow rate until it reaches 20 centimeters of water, turn off the oxygen and see if that pressure is maintained within the system. If it is maintained within the system, you're going to open the pop-off valve or the APV valve. You're going to open that up and then you can release your hand off the end of the circuit. And the reason we release our hand off the end of the circuit last is because if you don't, the soda line comes out of the canister and into the breathing system. It's really important to do that process correctly so that we don't get any of those little tiny particles through the breathing system. You're going to choose the correct rebreathing bag for the patient. The correct size rebreathing bag is the weight of the patient times by the tidal volume, which is anywhere between 8 and 15 mils per kilo. So we round it, so we generally say 10 mils per kilo, and then we times that by 6. So it's 6 times the tidal volume of the patient, and then we increase, round it up to the next size bag. So for example, if we've got a 10 kilo dog, we times that by 10, which gives us 100 mils. So that's our tidal volume of the patient. We then times that by 6, which gives us 600 mils. So the correct size rebreathing bag for that size patient, a 10 kilo patient, is going to be a 1 litre bag because we're rounding it up. Bags, rebreathing bags generally come into the size of 500 ml, 1 litre, 2, 3, 4, 5, and so on from there. But generally, we don't actually stock bigger than a 4 litre bag in our practice because our patients generally aren't that big. And you're going to find out what the best equipment that is needed for the patient. So find out what monitoring you want on the patient and make sure that that equipment is available and it is actually working efficiently. So when the patient is anaesthetized, you don't have to scramble around for extra leads, making sure it works, all that sort of stuff. Again, we go back to our pre-surgical checklist that we started this lecture with because it's going to decrease any adverse effects, events as much as possible. So making sure that we have the correct patient, making sure that we have the correct surgery plan on the correct limb, making sure that they've got the correct drugs, the clinician has checked the bloods, everything like that, making sure that that is all cross-checked. We're then going to calculate the drugs, and this includes emergency drugs. So each and every one of our nurses, before they anaesthetize the patient, and this goes on part of the pre-surgical checklist as well, is have you calculated the emergency drugs? On the back of the anaesthetic, so the anaesthetic chart, so anything that is anticipated to be given to the patient, so example, our calculations of emergency drugs, it goes onto the back of the chart because we haven't actually administered to the patient yet. When it gets administered to the patient, it then gets put onto the front of the chart. For example, 1 atropine at this dose rate was given, so that everybody knows exactly what the patient has been given and everybody knows that the emergency drugs is all written on the back of the chart for that patient. It decreases the response time, particularly if you don't have heaps of people in theatre. If somebody does come in and help you, all they know is they've got to check the anaesthetic chart and the back of the anaesthetic chart, and it's all written there ready for them to administer for you. We also want to make sure that we've got a fully stocked crash cart, and each and every staff member knows where the crash cart is and what the drug doses are, how to find that out, how to calculate those drug doses, etc. And I do highly recommend that when you get a new staff member into your practice, make sure that's one of the first things that they find out, where the crash cart is, because we never know when a crash patient is going to come in the door. And we want to make sure that everybody in the building, all the staff in the building, know how to treat a crash patient. So therefore, they've got to know where the drugs are, where the syringes, needles, etc. are, so that they can actually be part of that CPR team if so required. So basically, based on the physical exam and history, you want to know all this information before you then go and start to administer anaesthetic drugs. And again, this is making it the safest thing possible for the patient. Any of this information is going to help you foresee or eliminate any sort of emergency that may be able to arise. And we want to be able to treat our complications at the earliest possible detection. And the reason this is if we're keeping on the ball, monitoring the patient very slowly, we're going to pick up on these these changes very, very early, and then alert our clinician to it, so then we can go ahead and treat those complications if we do see any. Okay, moving into drugs, and we're looking at our pre-medications. If you're in a specialty practice, or if not, have they come from another clinic? Have they been administered any drugs from any other clinic? Is it what we would think that we would be seeing our patient? For example, if a patient comes in obtunded, if they've been to another clinic, it could be because they've been administered drugs from another clinic. If they haven't been to another clinic, well, we know that this patient is really, really sick. If they have been given medications from another practice, it means that we don't want to overdose them. We want to make sure that we use the correct drugs in combination with what has already been administered. Is it going to be compatible with what you are going to administer? For example, with your opioids, if they've administered an agonist, you don't want to go ahead and administer an agonist antagonist if you still want that degree of pain relief on board. It's going to prevent you from getting the optimum pain relief for that patient. Looking at the patient, is it more sedated than what you would expect to see with a patient? So even if they haven't come from another clinic, think about what the owner could have given at home. For example, have they administered gabapentin to decrease their anxiety, trazodone to decrease their anxiety to come into the practice? Is this the degree of sedation that we would expect for that sort of a patient? Our opioids. Now, our opioids is a huge topic within itself, and it only forms a small amount of analgesic drugs that we use within our practice. So I'm going to touch on these. And again, if you need any questions on these sorts of things, please do ask me in the chat and we'll get to them at the end. So you're looking at your different class of drugs. So you basically have your pure mu opioids, and the ones that we commonly use in Australia are your fentanyl, your methadone, your morphine. We do have hydro. We do have others, remifentanil, that we use in our practice, but it's not ones that commonly are used because they are more expensive. Our methadone does have an NMDA antagonist effect as well, which means it can help with wind-up pain. Now, all the pure mu opioids are 100% compatible with each other. So therefore, if you start off on methadone as a pre-med, if you want to switch to fentanyl during surgery or morphine post-surgery, they are certainly interchangeable. So this class of drugs are totally you can use in conjunction with each other. Thinking about the half-life of the drug, making sure that you're not giving too much to the patient, because then obviously that comes with side effects as well. You then have the agonist antagonist drugs. So that generally this is the active ingredient of butorphanol. And how agonist-antagonist drugs work is they antagonize the mu receptors, which means it blocks those ones at the top of the screen. So your morphine, your methadone, and your fentanyl, it blocks those from reaching those mu receptors. So therefore, it's not going to provide as much pain relief. However, if you have accidentally overdosed on those drugs and you want to kick them off those mu receptors, which means that you want to still have some sort of pain relief, but we want to get rid of the side effects, you can administer butorphanol for that, because butorphanol is then going to work on your kappa receptors as your pain relief, but push those other drugs off the mu receptors, so we can hopefully decrease those adverse side effects that we may have seen with an overdose. With the partial agonist drugs, so this is your buprenorphine, so your Temgesic. This is a partial agonist drug, which means that they partially work at your mu receptors. So it's got a higher affinity to your mu receptors, which means that it's going to block those fentanyl, methadone, morphine. So these are not compatible with each other. Can you administer them together? Yes, you can. However, you're not going to get the best form of analgesia out of these drugs for your patient. Your partial agonist drugs have a ceiling effect. So therefore, the higher the dose, generally it means the longer duration of action that you're actually going to see out of them. You're not going to get any better pain relief. You will see slightly more side effects, but generally the biggest thing is that you're going to get a longer duration of action. And this is buprenorphine we would tend to use in patients that have got mild to moderate pain. It's certainly not something that we would use for severe pain. Your butorphanol, your buprenorphine has got a half-life of anywhere between 6 and 12 hours, depending on the dose rate that you actually use. Your half-life of butorphanol is generally 1 to 2 hours. Your morphine is going to depend on, again, all of them are going to depend on your route of administration, but morphine you're looking at about approximately 1 to 3 hours. Methadone you're looking at 4 to 6 hours, and your fentanyl you're looking at approximately 20 minutes. And this is why generally we use fentanyl as a continuous rate infusion, because it has such a short half-life. So the effects of opioids that you will see, hopefully you're going to get some sort of analgesic effects, because that's why we're actually using them. We want sedation in low doses for most of our analgesic drugs, some sort of amphora or excitement. And this is generally seen in cats. And you can see, even though buprenorphine is used for mild to moderate pain, you can certainly see this come out in buprenorphine. Respiratory depression. And I use that term lightly because you can actually see a more relaxed atmosphere with your respiratory pattern than if you don't use analgesics, for example, for a thoracotomy. And antitussive, which means it stops them from coughing, so it decreases the cough, and that's generally butorphanol we use for that. Hypothermia, so low body temperature, it can decrease their temperature. It can make them feel sick. And generally we see this with morphine. And when morphine is given to a patient that technically isn't in pain yet, so if we use it as a pre-analgesic, pre-medication before we go ahead into surgery, this can actually make them feel sick, and they can actually vomit. So that's your emesis aspect of it. Now, I'm not saying that it happens each and every time, but if it's going to happen with any particular analgesic or opioid drug, it's going to be your morphine. And again, this is when I tend not to recommend morphine to our clinicians post-surgery as well, is if the patient is a geriatric, if they are a pediatric or a neonate, because I want that patient to get up and eat. A diabetic patient, again, I want them to get up and eat, depending on the complication or the surgery that they've had. But generally, we need these patients to eat as soon as we can. And if they feel any sort of nausea at all, they don't want to eat. So those sorts of patients, I would actually put on a fentanyl CRI post-surgery rather than a morphine. Defecation, you can see, and you can see this fairly quickly after injection. So if you give a pre-medication, come back 5 minutes later, and the patient has actually had an explosion in the cage, this is what I mean. And again, it doesn't happen with all of our patients, but we certainly can see it. It is something to be mindful of. Have in the back of your mind, if the patient does have gross diarrhea. Again, this comes back to the history taking of the patient. If the owner has not indicated that the patient has had any sort of diarrhea whatsoever, it may be because of the stress of coming into the practice, or it may be because of the opioid that we've administered. Gut sphincter stimulation or constipation. Again, this is a lot. Humans see this with any sort of opioids, so bear that in mind. We want to see that the patient is actually passing feces post opioid injection. Mydriasis in cats, so the dilated pupils, bradycardia in dogs or cats. And again, we've got to be mindful of this bradycardia. If we've got a normal blood pressure while we've got a bradycardic patient, it doesn't necessarily need to be treated. We don't necessarily have to reverse those opioid drugs. We don't necessarily have to take any of that treatment away from them. It does depend on the blood pressure, how they're actually coping, but more often than not, you'll be treating the heart rate, which will increase your blood pressure. Looking at your different sedatives to go with your opioids, most commonly in practice would be our acepromazine, and then medetomidine. For our more critical patients, we would use midazolam and diazepam, and also one of those ones that the patient may have before they come into the practice is trazodone or gabapentin. And all of these combinations of drugs that we may be using, we're going to tailor that sedative to the requirement of the patient. So if we've got a severely aggressive patient, a severely anxious patient that we actually can't get near in the patient, can't get near the patient while they're in hospital, medetomidine may be the best choice for this patient. Bear in mind, we want the patients to love us in hospital. We don't want them to be fearful of us. We want them to be at ease with what we do, what we are doing with them. And part of that is making them feel comfortable. And if we can get the sedative and the opioid on board as soon as they come into the practice, next time they come into the practice, they're going to like us a little bit more. Next time, they're going to like us even more. And this is certainly one of those drugs that you can actually use to win your patients over with you and make them feel a little bit more at ease. And generally, they will come around. Depending on the sedative that you actually choose to use is depending on the side effects. So your acepromazine is very vasodilative effect. So the patient's going to get cold quickly. Generally, they're going to have a lower blood pressure intraoperatively while they're anesthetized. Medetomidine, they're generally going to have a low heart rate. They may end up with some sort of arrhythmias with that as well. And this can be reversed, which is really, really important. Acepromazine, the side effects of acepromazine can be reversed, but the actual drug cannot be reversed. Medetomidine can be reversed straight away if you are seeing adverse effects from them. Midazolam is very, very short acting. This is a drug that I would use for my critical care patients because it is really short acting. So if you do have adverse effects, you can reverse them, or because they are so short, you can just support the patient through. Diazepam, again, can be reversed, but it's a longer duration. So it's a benzodiazepine, just the same as midazolam. And again, your trazodone, your gabapentins are all oral medications that you can give. Just a FYI, trazodone is compatible with acepromazine and medetomidine as well. So the neurolept analgesia is a combination of that sedative or tranquilizer together with an opioid. And in turn, we can get a better level of sedation with using decreased doses of each and every drug that we choose to use. And this is an advantage to us as the technicians monitoring the patient, because we are seeing decreased adverse effects of each individual drug if we were having to use it at a higher dose. So therefore, it makes it an overall safe anesthesia plan for the patient. And again, it's your clinician that will be drawing up this plan, not you, but you're going to know how those drugs actually affect the body and how they affect the patient. In turn, you know what to look out for when those drugs are actually used. So it's really good habit to get into, to learn your drugs inside and out that you actually have available in your practice, so you know what to look out for. Okay, so moving on to the induction of the patient. So we can induce them with alfaxolone, propofol, thiopentone, or our neurolept analgesia that we actually just explained, so a combination of drugs. Diazepam ketamine is one of the most common ones, or if they're really a critical care patient, midazolam fentanyl can be used as a co-induction agent as well. And each of these drugs have, again, different side effects that we have to be careful of. I don't know if it is the same over in Singapore or not, but alfaxan is by far our mostly used induction agent here in Australia. Yes, the Australians make it. However, it is still really, really expensive. But we like it. We like that we see less side effects to the patient. We see less apnea, which you will see with propofol if you don't administer it properly. The longer duration of action with your thiopentone, why the patient actually metabolizes those drugs. I'm not saying that you shouldn't use the other drugs. I'm saying that you should be comfortable with the side effects of each and every one of those combinations of drugs or individual drugs, so you as a technician or a nurse knows the effects of the drug, so you can keep an eye on the patient closer for that. And again, if you are doing it under the supervision, you are actually allowed to inject these drugs under the supervision of a veterinarian. You're going to be administering it the correct way. You're going to be titrating it to effect so that you use a lower dose, the lowest dose possible that the patient requires to be intubated. Therefore, you're avoiding as many side effects as you possibly can. Then we go on to the intubation of the patient. So the picture on the left of the screen here, you can see how to hold the tongue and the laryngoscope on the patient. And it's really important that the tip of the laryngoscope, so you can see on the right of your screen, the tip of the laryngoscope does not touch that epiglottis. So your epiglottis is the one that's in the V shape, just in front of your arytenoids there. You can see that dark hole. That's where the tube actually goes when you intubate them. But it's really important that the laryngoscope blade does not touch that epiglottis. And the reason this is because you can cause tissue trauma, which causes edema to that epiglottis. And although the patient has a tube in it for anesthesia, when it comes time to remove that tube, if that epiglottis is all swollen up because we have caused trauma, inadvertently trauma, by putting the laryngoscope on it, they can actually occlude when they're recovering. So I highly recommend that, so back to your left side of the screen here, holding the tongue in between the two lower canines. This guy came in for a dental, so his canines are very short. You can barely see them. So you're You're holding the tongue in between those canines with one hand. You're also holding the laryngoscope with that same hand, while the tip of the blade of the laryngoscopes go to the base of the tongue without touching the epiglottis. And then as you push down on the tip of that laryngoscope blade, it actually opens it up so you can see the two arytenoids, and your tube goes between those two arytenoids. When you intubate the patient, it's really, really, really important to make sure that you have the correct length tube. So we measure each and every one of our tubes, and it goes from the tip of the shoulders to the, which we classify as the thoracic inlet, to the incisors, and that is the correct length of ET tube. And all of our tubes get cut. Now, I'm not telling you to go back to your practices and cut your ET tubes. Your bosses may kill me. However, that's how the correct intubation should be done. That's the correct length of tube. As you can see with the X-ray on the right of the screen, that ET tube is right down into the main stem bronchi of the lungs. It's actually going into where they have actually split, which is not good, because it means that the patient is not using any both sides of their lungs. They are going to continuously wake up and hyperventilate or become tachypnic because we can't keep them anesthetized, because they may only be using one side of the lungs. And then it causes the other lungs to collapse, which again is another complication to the patient. When it comes time to remove the ET tube, like the guy is on the left-hand side of the screen, you can see that he's very, 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 very awake. And that's okay. He's allowed to be awake, sitting up, enjoying that oxygen, because he's probably never breathed so much oxygen in his life, because he's a brachycephalic patient. And he's holding onto that tube for forever. And he did. He took it. He was actually one of our patients that was walking around the practice with an ET tube in. Now, I don't recommend that if the patient is going to be sitting there chewing on it. This patient was not chewing on that tube. He actually was just enjoying a patent airway, and he was 100% supervised at all times why that ET tube was in. And again, as a nurse or a technician, this is really important. If a patient is intubated with that tube in, it must be a one-on-one monitoring, and the nurse or technician that is monitoring that patient must have nothing else on their mind except for that patient and that ET tube, because they can chew it off really, really quickly, and they can inhale the tube, and then you've got an emergency on your plate, which is not ideal. Sorry, just moving back to the intubation. Once you have the correct length of tube, you've intubated the patient, you connect them up to the oxygen that you have running because you've pre-oxygenated the patient. You connect them up to the anesthetic circuit. You then check the cuff on the tube to make sure that there is no leaks by closing your pop-off valve. Fill your pressure in your rebreathing bag to 20 centimeters of water while somebody's listening down near the patient to see if there's any leaks. If there's any leaks, you're slowly inflating that cuff until no air escaping can be heard. Once that cuff is inflated, you can then open your pop-off valve to release that pressure. Then you're going to turn on your isoflurane, your inhalant that you're actually using. And the reason that we do it in that sequence is because if you do have somebody pregnant in the building or in the room, it's a lot safer for everything to be going down the scavenging system and you not breathing it yourself. And even if you aren't pregnant or can't get pregnant, the whole thing is that it's safer for every single personnel to do it that way. So always check your system before you're turning on your inhalant. Okay, so now moving on to the stages and planes of anaesthesia. What we're looking at is your reflex signs and your vital signs. Your reflex signs are your prepeval reflex, your eye position, and your jaw tone. So as you can see, the middle picture here, in the middle of the screen, we've got an eye that is actually central. If we're looking, and we can't tell at this point in time whether the patient is light or deep, because our eyes go central when we're light and they also go central when we're deep. So you're wanting it more on the top right of the screen, and as you can see, the eye is actually ventral, so it's rolled upwards because the patient is in dorsal recumbency. And I haven't split the eyes open at all. So you can actually see that the eye has actually changed position to what it was before. And that's what we're looking at a reflex sign. We can't change that. It's going to be the patient or the depth of anaesthesia that changes that eye position. Again, the same with your jaw tone. Your jaw tone, by checking that jaw tone all the time, if you do check it too often, the muscles do become fatigued. So we generally do it once every 5 or so minutes, so we can actually check that depth of anaesthetic. Unless we're worried about the patient, we're going to check it more frequently. We also use those reflex signs in combination with our vital signs. So our vital signs are our heart rate, our respiratory rate and effort, our end-tidal carbon dioxide, mucous membrane and capillary refill. Those are our vital signs, and when we're classifying our stages and planes of anaesthesia, it is our reflex signs that gives us those depths. So you have stage 1, stage 2, stage 3, plane 1, stage 3, plane 2, stage 3, plane 3, stage 3, plane 4, which now we are deep at stage 3, plane 4. We need to get them back up the ladder again. And we have stage 5, which is just about dead. So if you can't find a reference on these stages and planes of anaesthesia, please do email me. I can send it through to you. We use it all the time at each and every part of the patient being anaesthetized. If our clinician says to our technician, what stage and plane of anaesthesia is our patient in, we must be able to answer them. And having the patient light, deep, good is not a plane and stages of anaesthesia. We need the correct terminology. And generally we do this so our clinician is really happy and trusts our technicians because they do have that in-depth knowledge and understanding. And therefore remember that our technicians and our nurses are our eyes and our ears for our clinician. And they are able to tell where our clinician can't, particularly if they're scrubbed into surgery, they can't stop and assess the patient. Okay, so moving on to intermittent positive pressure ventilation. If the patient is not anticipated to ventilate well, as in a thoracotomy, if they're on neuromuscular blocking agents, do they have a pneumothorax? Do they have decreased lung compliance for some reason? It might be a tumour, etc. If intracranial pressure needs to be kept low because of head trauma, all of these patients should have intermittent positive pressure ventilation. If our patient is hypercapnic, so greater than 50 millimeters of mercury, they're acidemic, they're hyperkalemic, they have reduced myocardial contractility. These patients all need intermittent positive pressure ventilation. And again, we're aiming to keep it below 20 centimeters of water when we actually do provide that pressure. Generally, we aim between 15 and 18, depending on why the patient needs ventilation in the first place. So this is your manometer, and this will tell you what pressure you're actually breathing for the patient. So your peak inspiratory pressure is between 12 and 15 centimeters of water, and you want to try and keep it to that just because something might be happening in the lungs or in the thoracic cavity that you're not 100% sure of, so we keep it at the lower rate. Our tidal volume, as we mentioned before, is 8 to 15 mils per kilo. Generally, we say 10, so we've got room to move up or down. We want a positive end expiratory pressure. So that's the pressure that is left in the lungs at the end of a breath, which means that we don't want the lungs to totally exhale. We want some pressure to be left in them. And our inspiratory and expiratory ratio, and that depends on what we set that at, will depend on our ventricular filling. So generally we always set it at 1 second inspiratory and 2 seconds expiratory, and the reason is that we don't get that increased pressure on the to decrease our ventricular filling capabilities. With our analgesia, we've gone through our opioids, and those opioids is going to continue through to the post-operative period. So we've talked about how they are compatible with each other, etc., what you can use with each other. Our alpha-2s, which is our medetomidine, our dexmedetomidine, our non-steroidals, our local anesthetics, and also our adjunctive medications, our fish oils, our gabapentin, etc., can be used. So our non-steroidals, they're not to be used with in conjunction with any other non-steroidal or steroidal anti-inflammatory drugs. Some are registered for perioperative use, but can be used in the post-operative period, providing the patients are suited to these. So again, look at the age of your patient, look at your blood values of the patient, because it is going to be a patient in renal failure, so increased BUN creatinine values, that these drugs should not be used, and you would have to use another sort of therapy, another sort of anti-inflammatory for them. Remember, they can't be used in conjunction with steroids. It's really important. And again, this comes back to asking the client what medication is the patient on when they're administered and when they're admitted to hospital, because then we can work out if they are on another non-steroidal, we don't want to change it over. If they are on a steroid, we don't want to use non-steroidals at all. Our local anaesthetics that we use in clinic is generally we use bupivacaine, which is 5 milligrams per mil. We don't want to exceed 4 milligrams per kilo, and it is cardiotoxic, so please do not administer this IV. If by chance you do accidentally administer it IV, get an ECG on these patients, listen to these patients really closely, because it is cardiotoxic. The onset time is approximately 20 to 30 minutes. So if you're not seeing the effects, have a look at what time you actually administered it, because that's going to make all the difference. Your duration of action, depending on if you've got it used in conjunction with an opioid or not, is approximately 6 hours. And again, use it in conjunction with an opioid so you can get a longer duration of action out of it. Lignocaine is one that a lot of people use. It is a short acting, so we do get approximately a duration of 1 to 2 hours out of it, but it is an onset time of 5 minutes. So if you want to do something straight away and you can't afford to wait, it's going to be the lignocaine that you're going to use. But remember, you don't get the long duration of action out of it. Again, you can use it in conjunctions with opioids. You can give it IV in dogs, not in cats. And you can get a better overall analgesic plan with it. Remember, when you do administer it to, in particular cats, because we use lignocaine on their arytenoids when we intubate them, use that dose that you've administered on the arytenoids in combination with the local anaesthetic that you use elsewhere in the patient to make sure it doesn't exceed to 6 milligrams per kilogram, because we cannot go above those. What's the side effects? What's the toxic side effects that you see of these drugs? Generally, it's seizuring, and yes, you do treat it as a normal seizure patient. But again, don't go up to those doses that high and you won't see those side effects. The reasons for neglect of analgesia is because they are really, really difficult to recognize. The misconceptions about the use of analgesia, as in they cause respiratory depression, so therefore I don't want to use it, for example, in a chest trauma patient, because it's going to cause respiratory depression. Well, no, it's going to help the patient breathe better by using it in those, because they can relax, because they do have opioids on board. So therefore their respiratory effort is going to be a lot better. Limited number of use of licensed products, how we get those products to the patient, as in they're always locked away. Only clinicians are allowed to touch them. So therefore it's difficult to get to the patients all the time. And then we're also looking at the potential side effects. However, this is no excuse for not providing analgesia for our patients. We, as nurses and technicians, we speak on behalf of the patient. And if we notice that our patient is in pain, by pain scoring them, etc., this is when we are going to be saying to our clinicians, hey, little Fluffy needs some more analgesia now. We think he's in pain because of this, 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 and this. And then the clinician can come and assess the patient and say, good pickup, let's give him some more analgesia. And just because the surgery is finished, it doesn't mean the analgesia needs to be finished as well. Again, we're sending the patient home with something, whatever it may be. Generally, we send them home with a non-steroidal in conjunction with tramadol. And I've popped a little Panadine extra down there because now that's the new fad with treating patients in hospital or at home, is a little bit of Panadol plus your codeine is working, appears to be working quite well. I think we've got a few more studies to be done on this before we can all be comfortable with it. However, with the studies that have been conducted with tramadol, it's more the serotonin effect, so calming the patient down, that we actually see of this tramadol, and it's not actually providing enough analgesia, even though there is an opioid effect in tramadol. It's only a 10%. However, it's more the serotonin effect of this drug that we're actually noticing, not necessarily the pain relief. So watch this space. This is all changing at this point in time. And yes, we do pay our nurses here to sit down and lie down and recover our patients. We have a very large brachycephalic clientele at our practice. We do mostly brachycephalic surgeries on Monday, Tuesdays and Wednesdays so they can recover properly before they go home. And it is literally one-on-one nursing. The nurse is there to sit with the patient until they are 110% recovered. And nobody with these guys, they do not have the nurse leave their side for at least 36 hours post-surgery. And it doesn't matter how stable they are, they have a nurse sitting in front of them for that 36 hours. We make sure that we do the TPRs on the patient, depending on what the patient is had surgery for, is depending how frequently that TPR will be given. We're going to pain score them to making sure that if they do need pain relief, we're going to let the clinician know to see if we can up their pain relief. If they are dysphoric or have too much pain relief on board, again, this information we can take back to our clinician. We want to make sure that they are comfortable. So the guy on the left of the screen here, He doesn't want to be in a cage. It stresses him out too much. We can't afford these brachycephalics to be stressed. So he lies on the floor with the nurse with a teddy bear and everybody is happy. He's keeping calm. He's breathing really well with limited amount of noise. Our nurse is happy because she's lying there just watching him, and they're sharing the teddy as a pillow. And again, it doesn't matter how we recover them. We want to make sure that they are kept comfortable at all times. We want to keep them nice and warm and normothermic without getting hyperthermic, so too hot. We want to make sure that if there is a pregnant person in the building, or if we can, we want to make sure that they exhale the isoflurane while they're on the system, the anaesthetic circuit, before they're disconnected. So that means we turn off the isoflurane, we let them breathe oxygen only for up to 5 minutes if we can, depending on how awake they are. And once that has happened, that means the isoflurane is out of the patient, therefore that they're going to be safe to remove off the anaesthetic machine. Before we do that, before we turn off the isoflurane, we make sure that the bladder is expressed. We want an empty bladder. This is one thing that can stress a patient out in the recovery phase. And we note that on the chart to say that it has been done. Looking at our different types of emergencies, we've got our respiratory emergencies, cardiovascular emergencies, which comes into heart rate, blood pressure, your perfusion. We check by lactate levels, your electrolytes, so have they got high potassium, low potassium, sodium, things like that, or is it going to be drug related? Our respiratory emergencies, again, we make sure that we have ET tubes on standby. We make sure we have more induction agents on standby, and also reversal agents. So if they stop breathing, is it because of the agents that we've administered, and can we reverse them so we can limit those side effects? Again, with cardiovascular emergencies, what is causing the emergency? So if they're slowly going down bradycardic, do they need atropine? Do they need the medetomidine or dexmedetomidine reverse to increase that heart rate? If our blood pressure is low, we have to work out why is it low. Is it because of the vasodilative effect of the drugs we've administered? Is it because the patient is too deep? Is it because they're too cold? Is it because they're hypovolemic, so the blood volume is not there? We have to work out why it's low, so then we can administer the correct drugs to correct that. The perfusion, again, if the perfusion, so if they are hypovolemic, so low blood volume, the perfusion isn't getting out to the periphery. We have to increase that perfusion, so therefore we can decrease our lactate levels. And again, correct the electrolytes, the ones we actually see, we recognize, correct them as soon as we can, but not too quickly. That's just as important. Again, drug, if it is drug related, we can reverse the drugs if need be. If it is an anaphylactic reaction, like we can see here, this is obviously not a patient that's anesthetized, but you can see this come through anesthesia. We want to make sure that we treat it. So the side effects or the signs that you can actually see is the patient can become hypoxic. They can have vasodilative hypotension, so decreased blood pressure because we've dilated our periphery. Tachycardic, so increase in heart rates, arrhythmias, so irregularities of the heart, shock, bronchoconstrictions, and pulmonary edema. And again, what we're going to try and do is reverse those side effects that we actually see. And the more that we can reverse it, the more that we will be able, the more we can actually identify what the actual problem is. We treat that problem, so then we can go ahead and make sure that we've treated it adequately. So in summary, if you have a proper history and do a proper assessment, be completely set up and prepared, you can help eliminate any of these emergencies that we have spoken about. Know your disease states of the patient and how they actually affect the body. Know your drugs that you're administering to the patient or the clinician has asked you administered to the patient, so you know what to look out for. Know your patient really, really well and be prepared. Okay, that is all. So do we have any questions?
I've got a question. Would you be able to share your protocol on patient fasting times and with regards to water and food as well?
Yes, so generally what we do is we fast them from food, depending on the patient, because each and every patient is different. But if it was a normal, healthy patient, physical status of 1, we're looking at fasting from 8 p.m, food, and they're allowed water up until they come into the practice that morning. If they are a diabetic, that is obviously changed. If they have a physical status of 3 or above or an emergency, again, that changes.
What about those patients who have to take, like, for example, gabapentin or trazodone before coming in? Are they allowed a little bit of food? Because usually the owners would have to sort of give them a bit of food with the medication. So is that okay?
A mouthful of food is okay. So the current fasting protocols now that they've done study on, they only have to be fasted for 3 hours. So again, that's generally what we would recommend for a neonate or a pediatric, well, actually a pediatric, that's what we would recommend anyway. So the whole thing is yes, you can give them a mouthful of food, and you then look at what you're actually doing, you know, what time of day that you're actually doing it. And you just have it in the back of your mind, because when we think about it, if a patient has been hit by a car, we actually get the patient in hospital. They may have eaten an hour beforehand and we deal with it really well. So this is just something that we're mindful of. So make sure that you induce them to a slightly deeper plane of anaesthesia. Make sure that you get the ET tube in really quickly and the cuff inflated really quickly. So if they do happen to regurgitate, you've actually got a sealed airway, so you're less chance of getting aspiration pneumonia.
Thank you. Does anyone else have any questions? Feel free to sort of put it on the group chat, or feel free to unmute yourselves and ask the questions. Anyone? I've got another question actually. It's quite quiet. I've got another question. When you mention IPPV, would you be able to share about how you go about providing it?
Certainly. So generally what we do is we have the little manometer that you saw on the next screen. After that, we have the manometer as part of the actual anaesthetic circuit. We close the pop-off valve, or the APV valve. We close that. We provide pressure on the rebreathing bag up to 20 centimeters of water, nothing ever over that. And 20 centimeters of water is at the high end of what you wanting it to be. So as the slide says, it's generally between 12 and 15 centimeters of water, and that's not causing, generally it's not enough pressure to cause any trauma to the lungs. Once you've provided that pressure, you then release it, you open your pop-off valve. until you make breath.
Okay, I think I've got a question from one of the participants. So do you sometimes have to use paralytics when you ventilate? If so, which is your preferred choice and why?
Do we? We have the facilities to use it. So that would be your neuromuscular blocking agents. Do we routinely use it? No, we don't. Generally, we use a high dose of fentanyl. So anywhere, and this does not work in cats, by the way, because cats don't ever follow any textbook. They are not small dogs, trust me. Generally, you're looking at 10 micrograms per kilo per hour in a dog, and that decreases the respiratory effort enough that you can then easily take over. However, majority of my patients that we take into theatre, majority of them go on a ventilator. And we do this for several reasons. A, to get our staff extremely comfortable with using a ventilator, and at the lower pressures, it is actually quite safe for them to be on a ventilator, providing we're using those lower pressures and the patient is getting taken care of. And what it actually does, as soon as you turn the patient onto the ventilator or provide intermittent positive pressure ventilation, generally the patient, you get them at that only ever so slightly deeper plane of anaesthetic. And when you do that, the drive, because the capnography readings are lower, remember it's your capnography readings within your body, so your carbon dioxide levels within your body, that drives your brain to say, take a breath. So as your carbon dioxide is increasing, it says, you need to take a breath now, because if you don't, your carbon dioxide just keeps building up. And that's how we exhale. That's how we get rid of our carbon dioxide, which is the waste product within the body. We're actually breathing it out. So it's your brain that tells you that. So once you get them at a plane of anesthesia that their carbon dioxide levels are slightly below normal, so we're looking at on the ventilator, we would normally have them sitting between 40 and 45. It's not telling the brain to take a breath. So therefore, they don't have any drive to take a breath. They actually give up quite easily.
Okay, this
question.
Another question would be, do you have any special tips for intubation of cats?
Yes. My biggest tip is to make sure that the person who is holding the patient for you keeps them nice and straight, the head up high, not backwards. So you want them straight out and forwards. And you want them at a slightly deeper plane of anesthesia. So with your dogs, you can actually intubate a dog when they're at a lighter plane of anesthesia. If you do that with cats, generally what they do is they'll keep coughing and splurting, and you won't be able to get in between your arytenoids. So the whole idea is you titrate your induction agent into the patient till you get them at that slightly deeper plane of anesthetic. You then numb the arytenoids with your local anesthetic. You let that sit there for about 30 seconds to a minute while you're still providing oxygen to them. Check the depth of anesthetic, and once they're at the correct plane, so that slightly deeper plane of anesthetic, you then try and put your tube in. And generally in cats, even though they keep their arytenoids closed, you can actually see a tiny hole in the ventral aspect of the arytenoid, so down the bottom of the arytenoids. And generally you can get the tip of the ET tube in that, so then you can allow the tube to twist into the trachea. So you don't force the tube into the trachea, you just allow it to naturally follow it. And then the tube slightly twists to go in there.
Okay, does anyone else have any other questions? last question from me. What are your favorite ways to warm a patient under anesthesia and post-anesthesia, apart from, let's say, having a bear hugger? Because I think we don't get that as much here. So what are your favorite ways to warm a patient?
Okay, I don't work for anybody. I don't work for any of these companies. That's the first disclosure information I have. We use the hot dog, and I absolutely love it. And it's basically a heated blanket. We get them directly from America. It's basically a heated blanket that doesn't overheat the patient. And the reason I like the hot dog over any other heated blanket is other heated blankets on the market can burn the patients. I have not seen this with a hot dog, providing you follow the advice of the manufacturer, which means that the patient sits directly on the heat mat, which is really important. It has an alarm function within the hot dog itself. So if it can't physically reach the temperature that you've set the patient to be reached at within a 10-minute time frame, it will alarm at you saying, I'm not happy. And it heats the patient up. If you can't afford, it's not in the budget, you can't get it in Singapore, my next best thing is bubble wrap on all your limbs and your head. So after the patient is anaesthetized, they're intubated, you wrap every possible part of the patient in bubble wrap. I do not like warm fluid bags, so hot water bottles. I don't like any of those because I have seen them cause burns on patients. So we would either generally put baby socks on the limbs and then put bubble wrap over it. We then cradle the patient in rolled up towels, so we're actually keeping the hot dog, or if you don't even have a hot dog, keeping the towels up around the patient as much as you possibly can until they can go into theatre or come out of theatre. The one thing that is to be really, really mindful of is the patient loses most of their body temperature, starts to lose their body temperature as soon as they've been given their sedation. Because remember, your sedation causes vasodilative effects, which that's how they lose their body temperature. It's really important to actively warm your patient as soon as you go ahead and pre-med them. And then when it comes time to anaesthetize them, keep your surgical prep times to a minimum. So have everything there ready to go so that you keep them anaesthetized for the smallest amount of time possible and you're not drowning them. And we'll go through that in our next talk the next one of this series is the surgical techniques. Keeping those fluids to an absolute minimum so you don't overwet the patient so that you can keep them for warmer longer.
All right, thank you. So final question for tonight. Is there a preferred or better pre-medication for cats?
I don't have a preferred medication because I treat them all differently. I will see, what the patient is going to have, so what they've come into the practice for, what is their current medical condition, and how comfortable the cat is. So if the cat's going to eat me, they're going to get metatomidine, or if they're not able to have metatomidine for some health reason, they're going to get Alfaxan IM. And again, I treat the cats just like we do with the dogs. If they don't want to be in hospital and are really, really cranky, the whole idea of getting drugs into them early so we can keep them calm so they don't hate us, they don't hate being in the clinic, it's better off for the patient. So we do it without rushing the cat. We obviously try and do everything very slowly to see if we can calm the cat down first. If we know we're not going to win with that, I'll either choose if they're aggressive, they'll get metatomidine or Alfaxan IM. If they're not aggressive, I would even be happy just to go with acepromazine, plus your opioids with any drug you choose.
All right, thank you. Thank you so much for the webinar session today, Anita.
That's okay. Thanks for the invite, and we look forward to our next one.
Yep. So thank you everyone for attending today's session. There will be a feedback form. I've got the links just sent to everyone. So if you'd like a certificate of attendance as well, fill it up and then we'll be happy to send it over. A recording of this webinar as well will be posted on the SVA website sometime after. So stay tuned for our on our Facebook page for updates for the next webinar session. Thank you everyone and good night.
Good night, everyone.
All right. Thank you. Thanks, Chef. Thanks, Anita.
Thank you. Bye-bye.